Hari, good afternoon and welcome to a session on premature newborns. We're glad to have Dr. Harish N among us today to help us understand this topic. Premature babies, especially those born very early, often have complicated medical problems. Typically, complications of prematurity vary, but the earlier your baby is born, the higher the risk of these complications. And in this situation, it takes a specialist to help make sure that the baby is normal and healthy. The doctor will help us understand this role and a lot more. So, doctor, you have the stage.
Thank you. Hi everyone, I'm Dr. Harish, Senior Consultant, Apollo Cradle Hospital, Koramangala. So today we are going to discuss pertaining to the problems associated with the premature newborns. So we'll discuss what exactly is this premature newborns and what are the problems we will face during the course of their journey in the hospital. So when we define premature newborn, so all the babies who are born below 37 weeks from the postmenopausal age, we call them as premature. So again, in that we will divide into different terms. One we call it as extreme preterms. Extreme preterm or premature babies are those who born below 28 weeks. Then from 28 to 32 weeks, they are called as very low birth weight babies. Then between 32 to 34, we call it as early preterms, and from 34 to 37, we call them as late preterm babies. So when we mentioned about the premature babies, again, why these babies are born, why the babies need to be delivered at a certain gestation or else below the expected date of delivery. So there are a lot of factors which contribute to their delivery. So considering both the baby and the mother, so there is also a factor. One is placenta. So there are, we will divide into maternal causes. One is the related to the problems pertaining to the mother. Sometimes we might have to deliver them. So then comes the placental factors. Then the something which is related to the last one is related to the baby as well. So first, when we say maternal factors, there are a lot of medical conditions. So when we say maternal factors, like mother might be having hypertension, mother might be having severe anemia, mother might be having diabetes. So these are the common causes which we come across. Other like mother having some medical heart conditions where it's a life-threatening, where we might have to deliver. So these are the causes, some medical causes where we might have to deliver the preterm, expected below the expected date of delivery. The second mother-related issue will be the related to cervix alone. So mother sometimes might be having cervical incompetence. That means the cervix is not ready to hold the baby inside for a long time. In that condition, there is always chance that the baby might deliver. Then apart from that, mother also can have the hypertension, which is related to the pregnancy. Otherwise, also they can have some bleeding, antepartum bleeding, what we call as uh, placenta previa abruption. Okay, so otherwise, these are the common mother-related issues which might lead to the delivery of the baby. Then comes your placental causes. There are something issues related to the placenta where there is a placental insufficiency, we say. So those are the conditions like placental hemorrhage or sometimes the placental incompetence. So all those conditions can lead to baby being delivered early. Apart from that, there are certain issues in the baby. Baby's growth is very much compromised because of the mother conditions. Then also we might have to deliver the baby prematurely. So these are some of the common basic related issues in the mother and the baby which might lead to the prematurity. Sometimes infection in the mother also. There is what we call as chorioamnitis. So that also can lead to the premature delivery. Then once the baby is out, once the baby has been delivered, so what are the common problems that we face in these premature babies? So we will discuss the common things, the basic that we will generally in what we see in NICU and all. So most of these babies require neonatal intensive care unit because many of the babies who are born less than 28 weeks or less than 32 weeks, even 34 weeks and below, they all require NICU, neonatal intensive care unit, for the baby management and stabilization. Even for if the baby is stable, also sometimes we might have to feed because the baby's feeding habits are also not developed initially. So these babies, all these babies requires NICU. So babies who are more than 34 weeks and after that till 37, if the growth of the baby is good, then many of the times they don't require the baby to be in NICU. So let us discuss extreme. As I discussed, when baby is born below 28 weeks, they are called as extreme preterms, and then they are most of them will be less than kilo also. So what are the problems that we face in these kind of babies? So why problems are see many of the organs in the preterms or these small babies, they are in a phase of development. So especially what the most common or the most severe of the problems is the development of the lungs, because that is the one which make the baby to breathe, right? So when the baby's lungs are developing, so any sort of insult or any sort of injury or any sort of infection, that also can lead to the complications and all those things. So since the baby's lungs are developing, if we have to deliver the baby and the baby to come out, so the baby will not be able to breathe. So the baby requires ventilator, especially the smaller ones I'm saying. So they require to administer certain medications to keep the lungs, alveoli and all to be open. The baby requires prolonged ventilation, CPAP. So all these problems because the immaturity of the lung. Since the baby's lungs are developing, so preterm delivery can lead to the problems, particularly related to the lung. And these problems are solved with ventilation and CPAP, which is a non-invasive mode of ventilation. So which we will all will do, and that will help the baby to uh, maintain the blood oxygen levels and everything. So this is the one most important and the common problem that we face. What we call this problem as HMD, or hyaline membrane disease. So this is because of the lack of surfactant, which generally you will be producing in, but the quantity will be less, and the baby's lungs are also in a phase of development, so that will lead to the problems. The second common problem that generally we face is relating the problems pertaining to the heart as well. There is a whole what we call as PDA, patent ductus arteriosus. This is not a problem per se, but generally this is will be present in all these preterm babies. But sometimes this, if it contributes to the baby's breathing condition, then it needs to be treated. Otherwise, most of this PDA or the preterm babies, the patent ductus arteriosus will close on its own. So don't have to treat it unless the whatever the problem of this contributing to the lung issue. Many of the times this PDA can also leads to hemorrhage and other things. So as a basic principle, many of the times we might have to close. The third and foremost the important problem that we face generally is infection, because the small babies, the skin is not mature, the skin is in the phase of development. There is a lot of stages has to undergo before the skin is completely get keratinized, and also the skin is in is gradually improving. So any damage or any injury happens, or else because many of the times we have to put the lines as well for the babies to be fed through fluids, and also in those conditions that there is a chance that the baby might acquire infections, and that can lead to the problems. So these are the third important problem that we come across. And the fourth problem generally we say feeding intolerance. So why we see the feeding intolerance means the baby's gut is also in a phase of development again. So there are a lot of what is it? Muscles are developing, especially the smooth muscles in the intestines are developing, and there is what entity what we call as anti-peristaltic movements are also there will be there in the premature newborns. So when we feed the baby, sometimes there's a high chance that the aspirates will come out, or else the abdomen get distended. The child can have sometimes an entity called as necrotizing enterocolitis. So this is related to sometimes because of the immaturity of the intestine to tolerate the feeds. So this gets better when the child grows older, and then slowly it will improve. So this is the fourth problem that we will see. Then the fifth one is are the lesser important ones will be there can be a problem with the eye as well, because your retinal vasculature is also in the process of developing, and then any insult and any injury happens during that, there is smaller newer vessels, what we call neovascularization can develop, and that can all leads to what we call as retinopathy of prematurity. Okay, So these babies we need to screen from based on the gestation. We will screen till 40 to 44 weeks of gestation for the proper development of the eyes. So this will happen. This is happens post discharge and other things. Then the most important of all these problems is the development of the brain. So why this is important? Because any insult or any injury happens during the initial phase of the baby's life can lead to the long-term problems. So the most common problem that we will come across pertaining to neurological issue will be the intraventricular hemorrhage or neurological um, complication. So IVH, when we say there is in a brain there are ventricles where the because any insult happens, so the ventricles are filled with blood, and that can lead to problems like hydrocephalus and all those things. Baby might have convulsions or fits. So any injury or else the progression of the bleed to grade 3, grade 4, can also leads to the injury to other parts of the brain as well. So that all leads to the long-term problems. So many of the pediatricians will generally counsel before the baby being delivered regarding this. So when we are saying about the neurological injury, so it is always very difficult to say like how the baby is going to be when the baby is out. So that means when the baby is discharged and the baby is developing. So initially, by the overall well-being of the child, we can assess, but the complete assessment can happen when the child starts developing. So when the baby reaches around 3 months, when the baby reaches 6 months, so the neurological follow-up will be there every 3 months and till 2 years and sometimes up to 5 years as well. So these things we will follow in the subsequent neurodevelopment clinic. So what are the problems that we can face when the childs grow older? So, because any neurological injury happens, the baby can have a neurological disability. That means what we call as cerebral palsy. The baby can have learning disability. The baby can have cognitive impairment. The judgment skills will be poor. The baby sometimes will be having motor issues. So, these are some of the common issues that we will come across when the baby or the child gets older. So this will not be able to predict, but many of the times we can predict by considering the subsequent neurological screening, which we generally do in NICU, where we will do ultrasound regularly to look further bleed and any further progression of the bleed. If we found anything, we might have to do the MRI when the child gets like chronologically by 3 to 6 months. So and do just to prognosticate the parents. So these are some of the common issues, so like 4, 5 organ related issues which we have discussed. So coming to like the admission and coming to the discharge policy, then the how to educate the parents, and this is the most important. What I discussed is just the counseling part. Coming to the discharge part and how the parents to be educated and parents to manage themselves in home once discharged. So there is a criteria where we follow in our clinical setup where we will admit all children who is less than 34 weeks and their birth weight is less than 1.6 kilos, and and we will be able to discharge them once the baby reaches 34 weeks or the birth weight of, or the discharge weight of, or the NICU weight of 1.6 and above. So if suppose baby weight is say around 800 or 1000 grams, so the baby will be in NICU till 1.6 kilos, and then the baby will be discharged to the mother side. So why it needs to be till that times? Because many of these problems which I discussed, many will clear it off within maybe 2 to 3 weeks, but still the baby needs to be stayed in ICU for longer time. See, the most as I discussed, many of the organs are developing. The one and most important organ is your gut, the GI tract, where we have to feed the baby and all, because your intestines are developing. There are a lot of issues we face while feeding these children. So the first, we can't feed these babies who are below 28 weeks. The feeding has to happen after 28 weeks because we will not be able to digest all the milk, and then there will be a lot of regurgitation or aspiration all will be there. So once the baby crosses 28 weeks, we will start to feed through the tube. Okay, so we'll put one in an nasogastric tube and we'll place the feed through that tube. So initially, the babies will not be able to swallow and suck. Suck and swallow will not be developed. So the sucking will start appearing by 32 weeks. So till that time, the baby will be fed on the nasogastric tube. Following 32 weeks, the baby will be started on pallida feeding. Pallida are the spoon feeding. So once the 32 to 34 weeks the baby completes, that's the time where the baby will be able to do on he or she. So we'll be able to do like the sucking as well as swallowing. That's the time where we initiate the breastfeeding. So that's the most common problem, or most the long term problem will be the feeding thing only. Okay, once we feel the baby is taking palliative feeding well, we will be able to remove the nasogastric tube, and then we'll be able to shift the baby to mother's side. So during the period of this, the most of the mothers will be trained to give this palliative feeding and all those things, and subsequently they will be taught regarding the breastfeeding as well. Okay, so apart from that, the mothers also will be explained regarding the kangaroo mother care. So once the baby reaches the weight of 1.2 kilos, we will start doing the kangaroo mother care in the NICU. So they can be done till baby reaches 2.5 and 3 kilos as well. So that way will be taught to the parent, especially the mothers. So when they're coming to NICU for the to do all these things. So these are the basic education levels that we will teach for the mothers when they are in the NICU. So when the babies are there in the NICU, so that like mothers will be trained to handle them in home. So we will prepare the mothers how to manage the babies, the small babies, because many of them requires comfort, warmth, especially. So they need to be well dressed, and then the cap, the socks, the mittens. So everything should be well placed so that these babies should be kept warm. So they should not have this hypothermia to be developed. So once this baby reaches a certain age, say as I discussed, 1.6, so we will switch off the warmers and everything, and we will just keep the baby well wrapped, and we will place it to the give it to the mother, and then once the mother baby will be shifted to the ward, so we will look for the weight gain of the child. So if the baby is gaining weight every day, so with the supervision of the mother alone, then the baby will be ready to go home, and the mother will be ready to take care of the child. So it's always is the comfort and the education of the mothers, which many of the times required to required to handle these preterm babies. So once we discharge these babies, so how is the follow up and all? So once they go home, so we will subsequently follow every like sort of a week to 2 weeks once, just to see how the child is developing, how the feeding is happening, any issues there with respect to the maintenance of temperature, or any with respect to other any health conditions. We subsequently follow during the our subsequent follow-up visits, and we will monitor the baby's weight and neurological growth, head growth, and height also. So once the baby reaches 2 kilos, the baby will be vaccinated, and then we will monitor the baby 2 weeks till 2.5 kilos. And subsequently, once the baby reaches 2.5 kilos, we will call them for the vaccination and subsequent neurological follow-up, like once in 3 months till 2 years. So these are the basic things that the problems can come across in small babies, especially the premature newborns, and how to solve these problems will be educated to all the parents. So especially in home, because they'll have this anxiety of managing. Sometimes they're not ready to sometimes accept these preterms. So everything will be taught off to the parents. So these are the common problems and the problems to be dealt with and all will be discussed with the parents. Thank you. Right.